Welcome everybody to today's Penn AI Tech webinar. Penn AI Tech is the Penn Artificial Intelligence and Technology Collaboratory for Healthy Aging, an initiative funded by the National Institute on Aging. Today, we're very happy to have with us as our speaker, Dr. Amir Rahmani, who is a professor of nursing and computer science at the University of California Irvine, where he also holds the Samueli Endowed Chair of Integrative Health. He serves as co-director of the UCI Institute for Future Health and leads the multidisciplinary HealthSciTechGroup at UCI. His research spans mHealth data science, wearable and mobile computing, machine learning and agentic AI, affective computing, and biosignal processing. Dr. Rahmani's contributions have been recognized with the UCI Beall Applied Innovation's inaugural Faculty InnovationFellowship, the Nokia Foundation's Research Excellence Award, and the European Union's Global Marie Curie Fellowship. So we're very happy to have him with us today. Just to remind attendees that if you have questions, we'll have a Q&A session at the end, but you can also use the Q&A feature to post your questions for our speaker. And with that, Amir, I'll turn it over to you. Thank you again.
Yeah, thank you so much for having me. Definitely a pleasure of being here at UPenn and School of Nursing and also presenting my work. Wanted to mention that I'm a computer scientist by training, but my primary appointment is with the School of Nursing, and that's, of course, a privilege. And of course, I have also an appointment with the computer science department. So today my talk is around a few kind of keywords, if you will, that are all related to technology, the notion of living labs, wearables, and the roles in living labs, and also the agentic AI kind of solutions and how they're forming and kind of revolutionizing health innovation. So I would like to a little bit spend some time talking maybe separately about these terms, but also kind of trying to show you like when they all come together, how powerful they can be. So let me start with the idea of living labs, and because that's something that we at our center, Institute for Future Health, really champion. And the idea is that, of course, we know the benefits of having controlled settings, how we can control for certain, for example, confounders, how we can really kind of zoom in on the effect of, for example, a certain study or intervention that we have in mind. But of course, there are also a lot of limitations. The one big limitation is the lack of real-world complexity. And also, as a consequence of that, also lack of generalizability, especially if you have diverse communities and populations. And you may not also have all the stakeholders and their involvement. And one big problem usually is the fact that you end up having static interventions, meaning that you design everything from beforehand, and in the lab you can really kind of try to only test those. And because you don't have those kind of complexities of real world, you may not even need that kind of adaptivity. But when it comes to living labs, the idea is to have this powerful alternative to those traditional lab controlled settings. And the idea is to have this user-centered co-creation, a kind of a rapid iteration and an iterative loop. So the idea is that you can prototype or design something with users, with stakeholders, not for them, involve communities, go ahead, test it, quickly evaluate it. So it's really co-development, or not really developing for them. Test it, learn from it, and again go and kind of change it over time so that eventually through this rapid iteration and flexibility, you can kind of adapt to those real-world complexities and make something that would work in real-world settings, and which also helps with enhancing validity and transferability. There are a lot of designs, research design methods that are aligned with this kind of living labs. For example, many of you are aware of smart design or sequential multiple assignment randomized trials, where you really don't have one static kind of randomization trial. You have multiple interventions, and you see firstly, for example, randomize your participants, then you see who responds and who doesn't respond. And those who do not respond are again being randomized and then assigned to a new intervention or a combination of two different interventions. And the idea is really kind of understand what works for whom, or which communities or clusters of people. But one big requirement of running studies in living lab is the access to data, because now we're talking about longitudinal, remote kind of data capture, and we need a lot of data because now it's not only about your kind of study and your hypothesis, but a lot of other contextual things happen at the same time. You need to monitor those, otherwise you can't put things into context and so on. That's why really the lifeblood of research like that is big data, if you will. And I just put a paper from the other co-director of our center at UCI, Professor Ramesh Jain, who talks about the role of data, and also borrowed this slide from him. It's part of our center's kind of introduction, and which shows how much data a car generates every year compared to how much data we collect from our children every year. And this is really a modern car. I'm not even asking those. I'm not even saying those autonomous driving cars. A simple, like, standard modern car. Every aspect of it generates a lot of data, and that's why when something is going wrong, your tire pressure, there are always alerts because everything is being constantly monitored. So, but do we really monitor or kind of have enough data from ourselves or children? So that's why in real world settings, you really need to have that kind of data to understand what's happening. So wearables and portable devices, they don't need to be wearables. It can be like smart homes, portable devices. They are very powerful technology to help us collect that type of data. Maybe not as accurate as those clinical hospital-grade devices, but rich in terms of longitudinal data. And there are a lot of wearables these days outside. I know that you are familiar with many of these. For instance, Oura-ring and smartwatches like Garmin that we use a lot in our research. I'm wearing one of those, as well as devices for continuous blood pressure monitoring. This is actually a Switzerland company, Actia, or another device that recently I came across that called Lumia Health, which looks at your cerebral blood flow. Very interesting also device. And so you can look at many of these kind of parameters. In fact, because I like this technology, I did a little bit of search to see, because this is centered on aging, if things like CBF are associated with aging. And through my literature search, I found out that in healthy aging, your kind of CBF drops maybe around 0.5% every year, or every year. But for certain kind of neurodegeneration, kind of degenerative disorders, it can be as like almost tenfold, like an order of magnitude. Right? And now we can monitor these things real time and continuously, and understand some of these phenomena. But of course, there are many other sensors. I was just talking today about the sleep pad that we use for dementia patients, and to monitor their sleep, their physiology, from readings. Just $150 kind of a device that gives you a lot of data about the sleep quality and some physiology of respiration and so on. Core body temperature, this device that we used, for example, to understand circadian rhythm over time, because we know core body temperature is aligned with that. And also for sleep studies, Sleep Profiler is one of those popular one in the sleep community, looking at for sleep staging and so on. And the list goes on and on. I cannot, of course, cover all of these devices in one presentation, but just wanted to give you an idea. For example, another interesting device that monitors the amount of alcohol in your blood. It has a chemical sensor, and actually can, through your sweating, chemical analysis, your sweat can also understand your alcohol level continuously. And of course, the list can go on and on. But let me a little bit switch the context. Of course, I want to also cover some of the projects that we did in our center, in my lab. I start with this. The first one is a project we had from National Science Foundation, Smart and Connected Communities program. And it was around this, the grant was ended, but it was around the idea of community-centered maternity care and how we can help, especially in that study, underserved populations, to help them these pregnant mothers be more physically active and also better manage their stress and anxiety and so on. And we collaborated with certain community organizations. For example, in this study, we had Moms Orange County as one of a nonprofit organization that was our kind of partner, and they support home visitations in Southern California, and educations and all of those. And we work with them on a pilot study to kind of give these pregnant mothers smart wearables like smartwatch and smart rings to better understand their physical activity, and also provide personalized physical activity for pregnant mothers called Two Happy Hearts. That was our intervention, which was actually tailored for each individual, because we could really see their elevation of their heart rate, if they're really meeting the ACOG guidelines on the level of that 150 minutes of physical activity that every week they were supposed to do and so on. But as a side project, just showing the power of big data, we also noticed in some of our studies on using wearables, for example, Samsung wearable and PPG, we noticed that some pregnant mothers unfortunately ended up having preterm birth. And now we had data for 9 to 10 months, like second, third trimester, and a few months postpartum from these pregnant mothers, and almost every 50 millisecond data from them. Every person, every 50 millisecond, 9 months. You can assume how much data we had. And it's a living lab, right? Because they were just living their lives, right? It's what they didn't ask them to come to our lab and just measure the HRV. We had access to their entire life and data and all of those things. And we could even contextualize those. We knew that when they slept, when they had physical activity, all of those things, because it wasn't just HRV. So we actually started building some basic machine learning models to see if we can stratify the risk of PTB already at this end of second trimester. So can we really predict if someone is going to end up having PTB at the end of second trimester? And that's because we had a lot of data on this. And in fact, with the accuracy of almost 80%, we could predict, even though we only had like 60 participants and around 6 of them had preterm birth. Small pilot study. Imagine if you had like hundreds of participants, thousands, the accuracy could go even can get much better. And we noticed that certain heart rate and heart rate variability kind of metrics were highly predictive of preterm births. And we know that some of these are also predictive of stress and anxiety and those kind of things. And just to show you the power of actually big data, if you have a lot of data and living labs. Another study, this was more on loneliness and on whether we can detect in real time loneliness in real world settings, as well as if we can build just-in-time interventions to help with that. And the intervention was an intervention designed by my colleague, a clinical psychologist, Dr. Borelli, Jessica Borelli, on the role of relational savoring. And through an app, and mobile health kind of app. So the idea was, as I said, we wanted to really see if we can detect that acute loneliness zone and just send that intervention, trigger that intervention, mobile health intervention on the phone at that time. That's why this study had multiple phases. Phase 1, we just had simple observations or monitoring. So we sent EMAs every multiple times a day, and we collected a lot of data from these individuals, from their smartwatch, from their phones, from their smart ring, and also their EMAs. So a lot of passive sensing. And in the second phase, now that we had this data, we actually built models, like models that could detect loneliness. Because now we had ground truth was still self-reported. Now we build these models and we kind of split these into two groups, the group receiving our intervention and the group that is not receiving. And of course, at the end, we also kind of try to, at the also phase 3, continuous follow up with them to see if there is a lasting kind of effect. A very sophisticated study design, I would say, because we had passive sensing, we needed to build machine learning models, build thresholds, and also decide when to kind of trigger just-in-time interventions, and then they actually needed to do that relational savings multiple times a day or any time the just-in-time detected that they actually feel lonely at that time. As I mentioned, the setup was like smartwatch by Samsung and Oura Ring, and also an app, a passive sensing app that could look at their location, their calls, their messages, not the actual content, just the logs, or if they're calling someone, if they're not calling, it's inbound, outbound, even how many times they lock or unlock their screen. That was actually highly predictive, and some of those things. So a lot of passive sensing from the mobile phones. And in fact, we could get up to 80, almost 82% of accuracy and for predicting loneliness, only looking at passive data objectively, like looking at your wearable and mobile kind of footprint, like mobile logs or life logs. So our models were rather, I would say, even though we had this not a very big sample size, we could reach a good level of accuracy. But I would say the challenge was really like the intervention part, right? The adherence. We sent a lot of prompts. We detected a lot of push notifications, but you see almost throughout the entire intervention, 1,200 prompts, but only 18%, showing that perfect detection. I mean, the detection wasn't perfect, but good enough. Detection means nothing if the users refuse the intervention, of course. And that was a pilot study, and we wanted to learn and understand what are the barriers and how we can make the intervention better. But some of the barriers that through qualitative study we kind of uncovered was like mostly UX, like user experience type of barriers, and like high frequency. They didn't want too many prompts, or sometimes the timing was right in terms of, okay, they felt lonely, but for them, it wasn't the best time to do the intervention. Maybe they were already driving or in the middle of a class. You can't just do the right. So it's not just about detecting the outcome, but also it was the right time to do it, and many other things. Of course, I encourage you to look at the articles, but also some good benefits. Some participants mentioned that it helps them to kind of force themselves to think more positively, or grounded users in their present moment, away from academic stress, because they were all students in this study. Yeah. And because of all those barriers, I would say, unfortunately, the intervention kind of did not show in this pilot, and also sample size was small. We didn't see any statistical significant reduction. Both groups, our control and intervention, had some decrease, but it wasn't really very significant, at least the GIT delivery method, because of a lot of issues. So the takeaway, of course, is that detection window doesn't necessarily mean that delivery window, and just in time. Yeah, and of course, a lot of others. But so another takeaway of this study was a lot of outcomes like loneliness aren't just, you can't just build a population model to detect it. It manifests differently in every person. That's why you really need personalized models. And all of our machine learning models in this study was personalized. We built a model for each participant. We didn't use a population model. And that's why you see, for example, I'm just showing you two participants, participant number 8 and number 10. In number 8, some heart rate variability kind of features were highly predictive. Whereas for this participant 10, some of their smartphone kind of activities, like how much time they spend on entertainment apps like Netflix, those kind of movies and so not social media, like entertainment. Sorry, social media was a different category. That was highly predictive of their loneliness or the kind of communication patterns. That's just also shows that someone is more deeply physiological, some of them behavioral, and the need for building personal models and personalization is big when it comes to especially these complex latent constructs, if you will. We partially did I would say reproduce or try to reproduce the same kind of study in Europe, in Finland, but only the detection part, no intervention. This part. So the study was the same, like the same devices, same apps, same hardware. The population was at this time like first generation immigrants in Finland, and almost only for a month, about 4 weeks. And we wanted to see if there's also kind of a possibility to use the same kind of technology, but this time, rather than building black box machine learning methods, can we look at more explainable ML methods, like, for example, causal machine learning, to understand causal factors, like X, for example, cause Y in loneliness. That's why our method was quite different. We used this causal ML kind of pipeline of using causal discovery algorithms like PC to build the graph, the causal graph, and then try to do inference and refutation on top of that. And when you do causal analysis, you will have these kind of results like average treatment effect, or which can be like positive or negative. And these are actually the results from this study. And we notice this is a population level. Now this is because it's average treatment effect. In causal model, we also have ITE, or individual treatment effects. This is an ATE. Looks at the entire population, and this entire population of Finnish immigrants show that like those who had, let's say, ongoing calls and those kind of things, it pulled it towards loneliness, whereas, and also and that was actually counterintuitive. We thought if there was someone is calling more, they should feel less lonely, but in this population, it was the other way around. Maybe there were immigrants calling back home, the country, maybe that folk made them feel, I don't know, we don't know. But something that was really kind of useful in activity, like physical activity, was highly predictive. Like those who were more physically active and also had a better sleep, that kind of showed helping with loneliness mitigation. Yeah, so we had this call paradox, longer outgoing calls actually, and usage of screen unlocks cause increased loneliness, whereas it's like location was also interesting. We noticed that those who had visiting a higher number of distinct places helped them reduce their loneliness, and also spending more time at home. That was a bit counterintuitive. So maybe there's a balance that you need to have between, routines and safe chosen, places. And movement, of course, very predictive, like calories burned and physical activity and inactivity, both of them this highly correlated. Not correlated, I would say causation, because we did causal modeling, caused them to become less or more lonely. Let me now talk about another project which might be even closer to the focus of this center, because this is a grant we received from NIA, and in 2 months it's going to finish. And this is about a home-based culturally tailored intervention for dementia family caregivers. And as part of this study, which is an RCT, we have almost 400 or 350 participants from different communities, Spanish-speaking, Vietnamese, Korean. So we have these dementia caregivers, and as our intervention is a home visitation program that is delivered by bilingual CHWs, a 3-month program. Classic, no technology, human from the same community, same language. But the technology was used mostly to look at some of the outcomes objectively, like whether the intervention helped them to sleep better or better kind of to help them have lower stress and so on. We haven't finished the study, kind of the data analytics, because the last participant just finished the study, completed the study a few weeks ago. I'm just showing you some early kind of pilot results on the intervention and the fact that the intervention helped them with both sleep quality. This is just over a month, first month, and also with their stress during the 44 weeks. And this is the sleep quality, of course, looks at actigraphy data, and also the stress was by looking at heart rate variability over time, and many subjective self-reported data on depression, burden, self-efficacy. They all actually improved quite nicely, I would say, in this study. And many other, as I said, this is not the entire sample size, but it's a smaller early kind of data analytics. These two were the only statistically significant data. Hopefully, after we analyze the entire data, I will give you more up-to-date results. Another important takeaway of this study was feasibility. Really, kind of the average daily use of these smartwatches in family caregivers was quite actually decent and high. You can see almost 18 hours a day on average. They awarded this, and in different populations was different, but still overall, I would say very good. And this was actually for the smartwatch. This for a smart ring, because many of them wore both of them in this study. Some takeaway also from all these studies that, I just showed you 3 studies, but trust me, we have done tens of studies like this in which in our center we used wearable and portable devices, the mobile app for self-reported outcomes, mobile app to build and deliver digital interventions. So we noticed that we are reinventing the wheel for each study, building a custom app, custom project, and then the next one, and next one, next one. And that's why we kind of started to take a step back and say, let's build a platform. We can't just reinvent the wheel for each study. And that was when at that time we started building a platform called Zotyer, a mobile health platform, which is flexible and personalizable, meaning that it's like a Lego. You have all those components. Let's say you need notifications, push notifications for them to maybe complete an EMA, or you need push notifications to send reminders to charge the devices. You have a studio, small design studio to build digital intervention, maybe plug and add a YouTube link or video about certain coaching, or connect certain wearables. So we started building a platform only for our centers, like at UCI. We have more than 55 faculty members in our center affiliated with us. So we first built it for them and supported in many, many different projects, including NIH funded. But then since 2024, with the help of UCI Beall Applied Innovation, or our tech transfer office at UCI, we actually turned it into a service. Now that's available to everyone globally. We have users from almost a lot from US, Canada, Australia, Europe, using our platform to build their mHealth solutions. And actually, it's quite a short demo of the platform. If the time allows, I'll show the full demo, but otherwise, I'll just put the link on the chat box for you guys. But the idea is that we have already integrated a lot of devices. You can just drag and drop when you select which device you want. We also give you this simple studio that you can design your interventions, like a walking, for example, exercise. You can bring pictures, text. You can even make it triggered by a device. For example, you can say, send this intervention only on the mornings following a poor sleep quality reported by Aura. So these devices can trigger the interventions on the phone. The platform is closed loop and without coding. Trust me, building a closed loop platform where device data triggers something, half of your grant money will go only to design something like that. But we noticed that many of these can be done without, by just building a platform that is ready-made. All of those can just, in few minutes, design something like that already in App Store or Google Play, and your participants can use it. And also you can use it for self-reported outcomes, surveys, all of those, and scheduling them. Yeah, so the first half, I kind of covered a lot of variables and living labs and so on. I'd like to talk about another topic, the agentic AI. I know it's the era of AI agents, LLMs, and all of those. So everyone expects me to also talk about that. And I love to also talk about it. I do a lot of AI as a computer scientist. So I'd like to talk about the agentic framework that we built also at our center and published it in 2023. In fact, we were among the very first groups which proposed the idea of conversational health agents, like using agents in healthcare. And the platform is called OpenChaw. It's open source, and I'll talk about it later. But the idea is that LLMs have several drawbacks. First is that they don't have real-time access to context because they're pre-trained on a lot of other things. And that's why many times they're not up to date, so outdated. And they also have a very limited token kind of size or context that you can just use. And also they are unable to plan. Let's say if you really need a different plan, depending on, let's say you want to interact with a certain data and make decision, all of those, this planning, they were incapable of planning. That's why we kind of started really championing the idea of AI agents. These days, everyone talks about it, but trust me, in 2023, when we published our first paper on OpenChaw, on archive, many people were not very receptive. In fact, a few times it got even rejected. But finally, in 2025, it got accepted by Jamia. And of course, the platform has been around since 2023, and many people use it. But you see, sometimes the adoption of technology, especially in the peer review community, is not really kind of fast. But the idea of, and if I want to simplify the idea of agents, is that agents or in platforms like OpenChaw, they are LLM agnostic. You can bring your own LLM. You can have open source, or you can use OpenAI's API. So you don't need to train anything if you don't have to. And oftentimes, I believe you really don't need to train or fine tune. You can just build agents that can tailor to what you want to do. But what they have this brain or their orchestrator, and the orchestrator can connect and communicate with external sources or tools. And that external source can be sometimes data. For example, you can just bring data from EHR. You can bring data from wearable devices. Or external source can be knowledge. You have, for example, NIH UMLS knowledge graph or knowledge base. Or you have NutritionX knowledge graph about all the foods, on their nutrients and all of those. So you can connect them to those validated sources. Or knowledge can be just PubMed. Say, don't search to Google. You only are supposed to, or only limited to PubMed if you want to search. And you also have access to connect to external models. Let's say you've already built a model for loneliness detection, or for your watch has an arrhythmia detection model, right? You don't need to just reinvent the wheel or send a lot of time series data to LLM. You can just tell it, when the person is asking something about arrhythmia, just go and call that existing deep learning traditional ML model or decision tree or rule-based, whatever. Bring the data. Don't try to do everything by yourself. So in other words, their orchestrator brain perceives, so ingests a query, a metadata. It transforms that into certain kind of structured data that the LLM can process. And it does thinking and planning like a robot that step by step it says, okay, first for this question, I need to go and retrieve the data. Then I need to pass it to this model. Then I need to do, so it can plan. And these days you see it all, with all these LLMs, of course, even GPT does that, right? But it wasn't that obvious at that time. But the idea for healthcare, there are very strong tools because now we can limit them to exactly the type of resources we want them to do. It helps a lot with hallucination because they don't need to just go and search the internet and give you results. You can tell them, okay, if something like this happens, these are your certain guardrails. Never do this. Always do that without training. Okay, you can even enforce them to do those kind of things. And also the fact that they don't have that limited context window and they have a data pipeline and they can bring as much data as they want makes them also much stronger than just using LLMs. OpenCha, as I said, has been around for a while. We have had many hackathons in Bay Area with Stanford University, recently at UCLA, and also with collaborators like NVIDIA and a bunch of other companies on building AI agents for healthcare. We have recorded most of these workshops. Everything is available on GitHub on our website. Please feel free to visit our website, opencha.com. It's an open initiative, as I mentioned, about our platform. We're, of course, more than happy if you guys want to contribute back to it. I think I have time. Maybe I can just show you this 3-minute video, a demo of OpenChat. It's a bit old. I recorded this 2-3 years ago, but still, in my opinion, has a lot to learn from. Because it has audio, I need to go back and share.
In this video, we demonstrate an example of personalized food recommendations on OpenCHA. We first select the tasks that OpenCHA can perform to generate the response. We select the task to interact with users' food data and health outcomes collected from external wearable devices, and one task utilizing causal inference algorithms to estimate nutrition effects. Then we take 2 tasks retrieving food nutrition content relevant to the user's query and requesting additional information from the user.
This was just a setting. You don't need to do it every time. These are just telling the chat that these tools are available to you. If you need it, use them. So you're not hard coding anything. It's just saying, okay, you have a tool. If someone asks information about EHR, I'm giving you the tool to go and retrieve data from EHR.
Let's start by asking the agent to show my personal nutrition effects on a specific health outcome, such as deep sleep.
The agent, OpenChat here in this scenario, is connected to a real N of 1 data set of one individual that monitored himself for 3 years, or an Oura ring. We have sleep of 3 years of this person, log every meal, measured everyday blood pressure, everyday weight. So very rich N of 1, of course, only 1%, and donated his data to us. But now, because there's such a rich data, if you ask questions like, can you show me my personal nutrition effects on deep sleep? The agent understands you said my. It cannot give you just generic advice on these things help people have a better deep sleep well. That's why it plans.
To do this, OpenCHA will collect data from a food log and deep sleep information tracked by a wearable device, subsequently estimating the causal effects of nutrition on deep sleep. The response will reveal the nutrition effects on deep sleep, with values indicating the estimated average treatment effects of the nutrients per unit.
So it says, okay, based on what you ate in these years and on those years, and I noticed that on those days that you have like a rich food rich in vitamin E or rich in zinc and low in caffeine and blah, blah, you had a longer or better kind of deep sleep quality.
We can also ask for food recommendations by querying the foods to improve certain health outcomes. For example, we say like, could you recommend me a food to improve my deep sleep duration? This will trigger the agent to execute the retrieve food task to obtain the relevant foods and their nutrition contents and personal nutrition effects. The response demonstrates the food suggestions to improve the deep sleep and the explanation based on the estimated personal nutrition effects. The recommendations are explainable. By querying with "Please explain your recommendations," OpenCHA will display the rationale behind the food choices, focusing on their nutritional impact. But what if you're missing an ingredient or food? No worries. OpenCHA's interactivity comes into play. Remember that this isn't just a static food list. It's a conversation with your dietary needs. Ask a follow-up question like, "I don't have the recommended foods. What are my alternatives?" And OpenCHA adapts, offering alternative suggestions. By calling the tasks, OpenCHA not only delivers nutrition-oriented food recommendations, but also enhances the user experience with personalization, explainability, and interactivity.
Yeah, this example, this demo, showed mostly the importance of connecting agents to your real data for personalization and that kind of interactivity, if you will, because it's really important. Different people have different level of access and different behaviors and so on. So you can't just suggest generic one-size-fits-all kind of recommendations. This demo was actually connected to the Centralight platform as an external platform because we have APIs and you can connect AI agents. And even let me also mention that we are going to organize a tutorial also in AMIA this year, and next month also in SBM, Society of Behavioral Medicine. We're going to also have a course at Chicago. If you're interested, feel free to sign up for those. Let me give you another demo, and I think I can wrap up. This is not going to be a video demo, just slides. But here I want to show the importance of external knowledge. I showed you the importance of external models and data, but what about knowledge? In this paper, actually, we wanted to see if when we give diabetes recommendations, nutrition recommendations for diabetes, if we do not connect these LLMs or agents or LLMs to real validated sources of knowledge, would they still be safe or not? So, and what we did, we built, so we had at that time 2024. So we had GPT-4 at that time. So we compared GPT-4 plus an agent built using GPT-4, which is connected to Nutrition X, which is the world's largest nutrition database. So this is actually about Nutrition X. It has APIs. You can connect to the APIs. You see how many grocery food items and restaurants and all of those and even the nutrients. And all of that information has been curated in a kind of knowledge base somewhere. So you don't need to generate. Generative AI only needs to be used for the generative part. If there's already knowledge, you should not generate, right? You can just connect to those knowledge. That's the takeaway. And that's what we did. But before even that, we actually conducted another study with some industrial partner on seeing even GPT-4, for example, a chat or GPT-4 or at that time other models. Are they even good enough? Can they pass the registered dietitian exam? It's the standard one that any dietitian should pass. And in fact, yeah, GPT-4 scored 87, which is above the passing threshold. This is a separate paper. Just wanted to show you if you're interested in that. We did that as well. But this is a result, just one case, a quick demo. When we use GPT-4 alone and when we use GPT-4 plus Nutrition X, so it's a very apple-to-apple comparison, the same LLM, nothing changed. But just the LLM is now forced to an agentic platform to not generate on certain things. So when we used GPT-4 alone, you see the question was this. I had spinach and banana smoothies for breakfast, blah for lunch, and certain things for dinner. Is the content of these meals appropriate for my diabetes? Okay. ChatGPT GPT-4 gave this result, like, your total carbohydrate is risky, your fat is okay, and blah. In fact, 2 of these answers were incorrect. Total fat and protein were risky. And when we connected this, so the agentic framework got out both of them correctly and said, yeah, the total fat is risky based on what I retrieved from the nutritionist blog. And actually, a nutritionist looked at our data, human, and agreed that agent is actually right. Just showing that with a quick connection, you don't need to retrain that entire, you can't even retrain GPT, you know, how many millions of dollars you need to retrain GPT, but just connect them to the reliable sources of knowledge and how important they can be. Yeah. So with that, I would like to maybe pause here. I don't think I have time to play that demo. It's about 5 minutes, but I can just put the link, it's a YouTube link for the Central Live. You guys can watch it later. And yeah, please, I would be happy to take questions. Thank you.
Thank you so much. I'm not sure if you have questions in the audience, but I know we have some questions here in the Q&A, and also to encourage folks to use the Q&A feature for those watching remotely for any questions for our speaker. One question we had was, you talked about the concept of living labs, and can you elaborate whether it's the same or a different term, and what the differences would be between this notion of a living lab and the learning health system?
A lot of things in common. I think there's a lot of overlap, but living labs don't really need to, in my opinion, it can be also a lot around preventive health. Like really, it doesn't need to be for patients. It's about people. We understand, especially when it comes to aging, longevity. The idea is that to be able to put things into context, and context matters a lot in living labs. You want to give someone, but just by giving someone a device and looking at the remotely, like a telemedicine, looking at the blood pressure, if you don't know what's happening to them at that moment, you only know what is happening to them, but why something is happening really need to living lab. So it's a multimodal, very rich data from any possible source. In my opinion, any possible source that you can get from mobile phones, from EHR, from anything that you can kind of build. I don't want to call it digital twins, but kind of a better term that we use is personal chronicle or personical of these subjects. That's why we love overlaps, but maybe certain distinct or more generic notions are also there, yeah.
Great. We have another question about your thoughts about creating safeguards for unintended negative consequences of both wearables, but also agentic AI.
Yeah, I think this problem definitely is a very valid and timely problem, especially for in agentic AI. And that's why I personally champion a lot the idea of building agents, not only for the solution or the kind of the application you have in mind, but also a lot of agentic evaluation frameworks, agents that can emulate and help evaluators, human evaluators, and also LLMs as judged. So because there are a lot of corner cases that you can't just ask human to cover all of those things. So agents can be also an opportunity for evaluation. And another idea or advantage of agents is the fact that you can now use them for different purposes. For example, you can use the agent to first analyze the query, because sometimes the query itself is unsafe, right? And if you can detect that, because you don't want to have garbage in, garbage out, or unsafe in, unsafe out, So you can use the agents to understand the inputs. You can use agents for disambiguations. You can use agents. Sometimes the user unintentionally is asking an unsafe. You can rephrase it, say, do you really mean this? Or maybe perhaps you meant that. The agent can understand that and help you a lot with that kind of, and as well as when the LLM generates something, now the output level, still you can use agents. You have a paper around the idea of constitutional AI, where you can define certain level constitutions. Say, for example, I want my agent or my chatbot to never recommend medications. Okay, this is just an integrated or behavior. And those kind of constitutions through the agent can be enforced, even if the LLM is unsafe, because the agent is a wrapper around it. It can double check, okay? It can, and also safety, which is very important. I just showed you the idea of knowledge. Oftentimes they're unsafe because they just came up or made up things. They don't have the right knowledge. If you give them the right knowledge, say, I want, for example, we're working with one hospital, and they wanted their chatbot to only use certain documents, educational materials that they have for their patients, and basically turning all of that into an interactive chatbot and not recommending anything outside those documents. Agents can do that, right? Because they can always check. And so you can use them in your advantage, in further to help you building more, safer things, if you will.
Thank you. Another question talks about how fascinating OpenCHA is and asking whether there's any intuitive patient-facing interface or if you have any plans for gamification models for egalitarian adaptations.
Yeah, as part of the OpenCHA, the open source version is more about the engine, the brain behind an agent. So mostly and it's application agnostic, right? So you can use that for building like a integrative health kind of application for food, or you can use it to build. We have groups that are using it to build like solutions for post-surgery, like instructions for cancer patients or different kind of solutions. So it actually offers only the brain. So the interface, all of those things are usually the application developer can add it to the system. But having said that, we also have the proprietary version of it that as part of our kind of separate activities, we build those solutions for a specific kind of problem. So if you're interested, reach out to me. That's not part of our center, but we have also activities that we kind of work with research groups and universities, especially those who have grants and so on, and we build something custom for them on top of OpenCHA. So CHA will be the engine or the brain, but a lot of shell so the core, but the shell will be, we can build it for them and with them if they're interested.
Another question about the loneliness living lab. Practically speaking, how long does it take before you have enough individual data for the personalized model to become reliable?
That's a great question and a very hard question to answer. I would say it depends on entropy or how much change you see in that person, right? Sometimes we really need like a 4-season data because this person can totally have a different behavior or context, maybe in summer. So sometimes it really varies person to person. Study we did, it was a few months, not even 1 season. But ideally, let me use this example that the industry part in different sectors do, and to build personal models. And that is companies like Netflix or YouTube or Amazon, Amazon of the world. What they do, the first day you go and create an account there, they create an almost empty personal model of you, or a population level personal model of you, if you will. And then starting from that moment, every click you make, everything you watch, everything you purchase, everything, they continuously try to update your personal model. And that's why after a while, they know so much about you that you're also surprised. Ideally, we should have the same thing in healthcare, right? If we have patient EHR data for years and people are wearing this device. So I don't have a good answer, honestly, for that. If like that, one data, if we could have at least 1 full year, that would be ideal because now we see the entire seasonalities and all of those things. But I would say a few months to a year would be good. But these are just my guesses, so they're not rooted in the science. Yeah.
I guess I know there's a lot of questions. We have time for one more. How easy is it for a healthcare facility without a computer science or data science team to use your open source tools?
For the centralized that platform building a kind of an mHealth solution, that's very easy. You don't need any skills. The idea, in fact, was to make it a service so that you don't need to code. For OpenJA, you still need help from if you want to, because that's just an open source code base. And still you need collaborators to help you build it. But having said that, if you're going for specific projects, and you have certain solutions in mind, reach out to us. We would be happy to, of course, we can't just, join every on each project, but we'd be happy to get to know more about your project. Even happy to go for joint grants. We have also a small kind of a spin-off from university. It's a small company that we kind of also serve and offer ourselves kind of agentic chatbot development. Reach out to us, or otherwise you need for the OpenChat you really need at least someone who knows a little bit, because you need to at least deploy it on a server and so on. Yeah.
Great. Well, I know there's a lot more questions and very interesting discussion that ensued. So I recommend that emailing Dr. Rahmani directly for further discussions. This has been a great presentation. I want to remind folks our next webinar is on April 9th, where we have Dr. Mia Takni from the University of Cambridge talking about methodological questions for digital outcome measures in clinical trials. And so with that, Amir, thank you again so much for this great presentation, and thank you all for attending today's webinar.
Thank you. Just want to make sure I put the links on the chat, but is anyone going to receive those? Just want to make sure.
I added them to the Q&A.
Okay. Excellent. Thank you.
Thank you all.